Any questions? Like, explain the role of stimulants in depression. Yeah, stimulants, I do look at it in the case of a later state. Generally, this is not the first line, not even in the second line. You know, like in the first line is like one of the SSRIs you give. Then you look at titration of the dosage. Then you go for the augment, and then switch, and then all those things we do that, and then only then the role of stimulants come. But no, like stimulants, one of the problem is that it can be like addiction tendency. SSRIs really burn cognition in the long run. There is something which has been talked about, but the problem is in depression, the cognition itself is so much it gets disturbed, and then for a long run, how long give that? It's like this. You give an antidepressant, the suicidality gets increased. That's what for quite a long time we lived with that. But this is going to be the problem with this. I look at it as a today in the same one, and as a clinical practice, I have not tested the cognitive improvement or cognitive decline over a period of time. We are planning to take up a study, especially with the vortioxetone has been introduced, saying that it's a cognitive improver. So comparing vortioxetone and then escitalopram, we are planning to do a study. I think that is what maybe if we get some results, maybe next time we can discuss about it. What way alcohol affects while treating a depressed patient? Alcohol is a central nervous system depressant. So on a general note, I tell patients, I don't say that, okay, stop alcohol lifelong, but alcohol can disturb your activity. And the problem is that alcohol sometimes can be like self-medication people abuse, and then it can go to the point of being like addiction. So at least for a period of 2 to 3 months, don't take alcohol. Generally, sometimes some patients come back and say that, doctor, can we have like a once in a while effect, maybe some relaxation depending on the patient, and then nothing more than that. Other than that, I don't say specifically that a total contraindication or anything like that. It's better to avoid. It's what general lifestyle management, avoid alcohol, have a good sleep rhythm maintained. This is what I do. That's how it goes. Right, I think we have come to an end of it. I think this is the 2 questions, and then thank you very much. Thank you very much for your participation. Thanks. I'll see you again tomorrow with some of the things what I have talked about. We'll discuss about this tomorrow. Thank you very much. There seem to be some best drug to treat resistant depression in your opinion. There's nothing like a best drug. You have to try. Most commonly used drug we use escitalopram. There's nothing like that. Sometimes imipramine is supposed to be the gold standard, but that doesn't say that you every patient you start on that. By the time he goes to the resistant depression, you would have tried few drugs already. Sometimes a combination may work. As I told, that augmentation with lithium, thyroid, some of these things may work. So you cannot say that this is the best drug. It's very difficult to conclude based on one particular drug. It's very, very difficult. Right, there is some question on antidepressant prophylaxis. Yes, I showed you that if there are more than 3 episodes, there's a risk of having a further episode, which is supposedly 3 to 4 episodes in a period of about 10 years. But how effective? There are some studies which have shown that it's a continuously giving antidepressants help in reducing the frequency of episodes, but quite a lot of times, I mean, there's not like even though there is data, a lot of times patients may not take it regularly, and then now like an in between there are only 3 episodes. First episode he completely recovers after about 2 months or 3 months. We continue for about 1 year and then stop it. So it is like that. Prophylaxis sometimes we do give, because in some patients when we reduce the drug there is a slight relapse of it. So remission on exacerbation of symptoms, in those patients we continue it. Unless otherwise, unlike in bipolar disorder, here they're strictly following antidepressants for lifelong. Generally, it's not indicated. That is how we look at. Sometimes we get to breakthrough depressions also, but continuously for lifelong bipolar, you say that lifelong continued treatment that is not being done in major depressive disorder. High dose SSRIs, generally the optimal dose is 20 escitalopram, similar, like almost equivalent to fluoxetine and other. But if the patient does not respond, the first thing I do is that increase the dosage to maybe 30 milligrams or 40 milligrams. Beyond that, in simple depression, I may not increase that, depending on how the patient is responding. If the response is good but not remission, they increase up to 30, 40 milligrams. But if it's not seen, then you have to take other calls like a switch or augmenting, like that. It's not like a continuous take. Depot preparations, as of today, right, we don't have any depot antidepressants as it is. It's only the antipsychotics. So usually depot preparations are not considered in antidepressant therapy at all. Maybe sometimes we wish that we have a antidepressant which is long acting, which is free of side effects, which we can take, but as I told that usually after some time, it's unlike, like as I told that in schizophrenia, the treatment is lifelong. Bipolar disorders, you look at, like a long-term treatment to prevent prophylaxis. Here, most of the times we don't look at it. Once the patient remission and recovery and then completely all right, and then unless there is a very frequent recurrences, we don't look at like a long term. But in some patients where it is required, definitely maybe it is like it may be useful. Fluoxetine is one drug which I can give once a week. Fluoxetine, I think one or two companies make 90 milligrams, and then we can give once a week. I think that should do, provided only problem is that fluoxetine gas, the side effects, like drug interaction is the side effect. So some patients you have a little bit, worried about at the time when they have the hypertension, diabetes, and all that. Otherwise, you can give it. If there are no more questions, I'll say thank you all. Thank you very much.